Hello, and thank you for joining the Pituitary Network Association's webinar program, which is brought to you through the support of our sponsors and our expert contributors. The P&A is dedicated to educating people with pituitary disorders, their families, and their healthcare providers. The P&A is a nonprofit organization that relies on the support from our members and donors. During the webinar, feel free to type in your questions at any time. Please note that all questions will be saved until the end of the webinar. We have allotted time to answer as many questions as possible. Today's webinar, The Natural History of Pituitary Neuroendocrine Tumors, is presented by Dr. Manish Aghi. Please hold as there will be a brief delay while we change presenters.
All right, great. Should we get started?
Yes, please. Thank you so much.
All right. Well, thank you, everyone, for being here this afternoon. My name is Manish Aghi. I'm a professor at the California Center for Pituitary Disorders at UCSF, and it's my pleasure to be speaking to you today about the natural history of pituitary neuroendocrine tumors. This talk will really consist of two parts, and the first is to talk about how common are pituitary neuroendocrine tumors and introduce you to some statistical concepts and some trends over time and some national data that can help us understand this. This is an important topic because as we, for those who are who have this diagnosis, I think understanding how common it really is, and to cut to the chase, the answer is that it's very common. It can be very helpful when it comes to finding resources such as the P&A or lobbying for congressional support, lobbying for insurance companies to provide access to care, et cetera. And for us as providers, it helps us understand how important it is to commit our resources to patients with pituitary neuroendocrine tumors. And then the second part of this talk will be talking about what is the natural history of observed pituitary neuroendocrine tumors. As I will talk about, many of these don't need treatment right away. They may be asymptomatic, and physicians may recommend that patients undergo monitoring with periodic MRIs, as often happens with benign asymptomatic tumors. And if that were the case, if you were in that subset of patients who did not have symptoms and could be followed, how often would we expect the tumor to grow versus not grow? And so that's what I'll be touching on in the second part of the talk. And so starting with how common these are, I think the first thing, just so we're all on the same page in terms of terminology, these are tumors that are undergoing a transition in their naming. So these were always called, and still are called, pituitary adenomas. But our colleagues in neuropathology are gradually transitioning towards a new naming system whereby the same exact tumor with the same exact properties and the same exact biology will now be called pituitary neuroendocrine tumors. And that naming is not necessarily the subject of today's talk, but I'm just presenting that information for background. And the second bit of background involves some terms that I'm going to be using a fair bit, which is incidence and prevalence. And so I think incidence, for those who haven't heard this term before, is the rate of occurrence of new cases of a disease or condition, in this case, pituitary neuroendocrine tumors. And this is typically monitored with registries or local surveys. And the important thing is this is defined per, fixed moment in time, so typically yearly. So the 2023 incidence would reflect the new cases that were diagnosed by MRI in 2023. You can also talk about the radiographic incidence, which is the new cases diagnosed by MRI, or you could talk about the pathologic incidence, which is the new cases diagnosed by pathology, meaning the tumor was removed. And then prevalence is the number of people with the condition in the population at any moment in time. And this is going to be not related to 2023, because it's basically everybody alive with a pituitary tumor, not just those diagnosed in 2023. And you would make it as the number of cases per 100,000 people. And so this can be assessed by local surveys or autopsy series, but it's a very distinct method of collecting this data compared to incidence, which is going to be measured by registries. The reason a registry can't tell you about prevalence is that it doesn't record whether the patient who was diagnosed in the 2016 registry with a pituitary tumor is still alive in 2023, so you don't have that information. But a survey or an autopsy series will tell you just across the board in the population how many people had the disease or the condition. The other way of looking at this is in this cartoon figure here, the incidence is the rain arriving on the ground, whereas the prevalence is the water in the puddle, which reflects new and old water mixing together within that puddle. And given, the reason these terms are important for pituitary adenoma or pituitary neuroendocrine tumor is that given the relatively good long-term survival, the yearly incidence of pituitary adenomas is actually quite low relative to the prevalence. And in fact, generally when we mathematically model this condition of pituitary adenoma or pituitary neuroendocrine tumor, we say that the prevalence is the incidence multiplied by how long somebody will live with the condition. And generally a conservative estimate is that patients can be estimated to carry this diagnosis for 22 years. This does not mean that pituitary tumors become fatal at 22 years. It just means that on average, a person will be diagnosed 22 years before their end of life. But obviously, there's a wide distribution there, and that is just an average. And again, this is not a fatal condition. This is just how long before they die of whatever cause they die of were they diagnosed. And so the important thing to know about prevalence is, if you somehow were to estimate how common pituitary adenomas or pituitary neuroendocrine tumors were based on cancer registries and tried to extrapolate from that the prevalence, you would still assume that they're quite rare compared to breast cancer, lung cancer, or colon cancer, which are also collected in those registries. But when you take people who are undergoing an autopsy just because they passed away, or people who volunteer to undergo an MRI, what we call healthy volunteer studies, you would estimate that pituitary tumors are 700 times more common than the registry data. And in fact, the autopsy data or the healthy volunteer MRI studies will show that 14% of autopsies or 23% of volunteer MRIs will reveal a pituitary tumor. And this actually gives a mean prevalence of around 17%, or 1 in 6 people having a pituitary tumor, of which about 1% will be macroadenomas. And this 1 in 6, numbering is very easy to remember, and in fact, for years was a slogan of the PNA, and I think it does remain sort of a relevant number even now in this sort of modern era, and it's much higher than the registry data would suggest. And here you see this in graphical format, that the MRI and autopsy studies generally show a prevalence of around 0.1 to 0.4, 0.5 per 100,000 people. So the question is, what causes the disparity where autopsies just show many more tumors than these registries that are collecting the data from clinical providers? And not surprisingly, this probably reflects a number of people with small, non-clinically relevant incidental findings that are diagnosed and followed but don't undergo surgery. And the reporting of these cases to cancer registries is not mandatory, at least not until recently. And then there's just many people walking around who get all the way to death without knowing they had a tumor like this. And so there's a number of people who get to the end of life with undiagnosed tumors, such as pituitary tumors. But importantly, when we do have our pathologists remove pituitary tumors from patients at autopsy, they look just like the tumors that surgeons take out when patients are alive and they have symptoms. They exhibit this classic architectural pattern where they lose the acinar staining of the normal gland, and the normal gland is compressed. And in some cases, a patient may get all the way to autopsy with a tumor that's actually not just there, but actually is functional. And in this case, you see an example of a prolactin secreting tumor in a patient at autopsy. These tumors also have a reduced vessel density compared to the normal gland. So all these properties are really suggestive that, you know, these are very common, and the types of tumors that people have at autopsy that they weren't aware of are really the same things that people had undergoing surgery for, but for whatever reason just weren't diagnosed during their life. When we, as I mentioned several times, I showed you an example of a patient at autopsy with a prolactin staining tumor. It turns out that 42% of pituitary tumors from autopsies will stain for prolactin. And in one series, they were able to collect blood in these patients and show that they had elevated serum prolactin during their life, and you know, about double what would be considered normal, but obviously weren't symptomatic because that elevation is mild. Most people at autopsy are, you know, if they're women, they're postmenopausal, and so they won't have that sort of amenorrhea that you would get if you had where the menstrual cycle stops if you have a mild prolactin elevation. And so it is tricky to diagnose hypersecreting tumors when someone is older, and that's what this data suggests. There's also elevated incidences of staining for growth hormone, ACTH. So these are patients who might have had mild acromegaly and reached the end of life without knowing it, or possibly mild Cushing's disease without even knowing it and reached the end of life. And so I think, you know, these are important pieces of data because, you know, we do know that even when patients are asymptomatic, having elevated levels of these hormones can take a toll on their life and their quality of life. And it's quite possible that some portion of these patients actually had symptoms and should have been diagnosed, but it was attributed to age-related change and other phenomena, but inaccurately. Interestingly, autopsy series show that the prevalence of pituitary tumors has remained very steady at around 0.125 per 100,000 people over several decades, and this can now go all the way out to 2023. It's not shown here, but very steady in autopsy. And so this is an important fact to keep in mind as I show you the number of cases that are being diagnosed over time, which is, to cut to the chase, going up. And so here you see another piece of data that the harder you go looking for a tumor, the more likely you are to find this. And this just shows when you do an autopsy, if you slice through the tissue with thinner slices, you're more likely to find adenomas. And so while I was quoting an incidence from the literature of 0.125, the reality is if all autopsies cut through the pituitary gland, you know, with 10 micron slice thickness, which is very precise, you could probably get an incidence of pituitary adenomas at autopsy that was even higher, of 0.25 or 0.3. This is an interesting study that I think I would take with a grain of salt, but it does represent a line of investigation that is sort of could be interesting to pursue in a variety of different directions, which is that, you know, post-mortem, when we find patients with pituitary tumors and we find patients who don't have pituitary tumors at an autopsy, it turns out in this one study that microadenomas were more commonly found in patients who were suicide victims than patients who are not. And I think this is an incredibly, you know, sample size of one study type, you know, caveats here. And I think more so than this issue of suicide, which is not really related, is the idea that I think if we look at autopsy patients and we have access to more information about not just how they died, but, you know, what health conditions they had, I think it's quite possible that we could be able to connect some hormonal perturbations that might have been caused by undiagnosed tumors that were undiagnosed during life, to something about these patients' lives. And that I think it's safe to assume that not every pituitary tumor found at autopsy was asymptomatic during life, is I guess the take-home message from that bit of evidence, the data. So as we dive deeper into prevalence, one study or data set that I have found interesting, it's a little bit old, but it is informative, is that in the province of Liege in Belgium, and these are the kinds of things that the European system is much better equipped to do than the United States system, but they performed a very intensive case finding approach at a community level, which essentially involved door-to-door knocking and recruitment of endocrinologists and primary care physicians in a community where everyone had access to care, universal health care, et cetera. They were able to collect a lot of reliable data on the incidence and prevalence of pituitary tumors. And this study was informative because it overcame inherent limitations in case reporting to registries. So when we talk about registries, the limitation with registries is that there isn't mandatory case reporting, but in this case, they essentially collected the data on every patient. And what was interesting, that they found a prevalence of nearly 1 in 1,000 for clinically relevant pituitary adenomas. So these people are alive, diagnosed with a pituitary tumor, and that prevalence is nearly 4 times the projected prevalence from registry data, such as the Central Brain Tumor Registry of the United States, or CBTRUS, during a comparable time period. And so this tells you that a small, 4-fold component of the 700-fold disparity between the autopsy and the registry data probably represents underreporting to the registries. So that means the remainder, nearly, almost 200-fold disparity, comes from something else, which we'll be talking about in a moment. So what's happened over time? So we, up till now, we've been ignoring time as a variable. Other than the fact that I did mention for autopsies, over time from the 1990s to the 2020s, there has been no increase in how often pituitary tumors are found in patients at autopsy. But in cancer registries, which is basically collecting data on pituitary tumors reported by doctors whose patients have had MRIs, et cetera, there has been an increase over time. And so here you see it in Japan. The Japanese Brain Tumor Registry showed that the incidence of pituitary adenomas has increased from the 1980s to the 1990s. And this trend has mirrored the trend in the number of CAT scanners in Japan. So this is obviously old data. We can update it a little bit more. And but before we do that, here's another piece of data from Sweden. From 1958 to 1991, there were increases in pituitary adenomas that were diagnosed in both men and women. And then more recently in the Swedish registry, the increase in males and females occurred in the early 1990s, did plateau a little bit after that. But this is really, I think, the most compelling data for the 2000s. So as I mentioned, CBTRUS is the Central Brain Tumor Registry of the United States. There's no mandatory reporting, but despite that limitation, the US incidence of pituitary adenoma has continually increased, starting at a pretty rapid rate from the year 2000 to the year 2020. The other thing that's interesting about this increase is that slightly less than half of these cases were diagnosed by surgery. So more than half were just diagnosed by MRI, and in patients who didn't undergo surgery. And what's actually happening is that both categories, the category of patients diagnosed by surgery and the category of patients diagnosed by MRI, are increasing over time. And so that's suggesting, if you put it all together, that we've got these fancy MRIs, we're getting scans on people with headaches and a variety of symptoms, and diagnosing these tumors more often. And that increase in diagnosing them is not just leading to a pool of people who are not undergoing surgery, it's contributing a small but meaningful increase in the number of patients who are actually being referred for surgery and who are diagnosed with a tumor that they, maybe weren't profoundly symptomatic from, but that did warrant surgical resection. The other thing about this data set that should be mentioned is that the incidence in males in this data set was a little bit higher than females, but I'll get to some of the gender disparities in one moment. This is an interesting study that overcomes some of the registry limitations. Again, in the US, the group at the Mayo Clinic had access to a smaller registry from Olmsted County, Minnesota, that recorded all diagnosed cases over a 20-year interval. And they found that there was an increased incidence over time correlating with the increase in the number of MRIs done during that time. But there was a degree of a plateau that tended to occur towards the end of this. And that plateau will show up again in this study, which is coming from yet another registry, the SEER database. So SEER is a group of 13 states that participate in a large cancer registry, and they collect data on malignant cancers as well as benign tumors. And they found that the overall incidence of pituitary adenomas or pituitary neuroendocrine tumors was trending upwards from 2004 out to 2016, but it did peak at 2015 and appeared to be plateauing, and that matches what the Mayo Clinic data set was finding as well. Then when they looked at this by gender and age, they found that for men, there's essentially a bimodal or unimodal age distribution, so it really peaks at one peak when men are in their early 60s. That is when they are most likely to be diagnosed with a pituitary tumor. This is incidence, mind you, not prevalence, which is important because those are new diagnoses. So if you get a new diagnosis as a male, it's most likely to occur in your early 60s. In contrast, women had a bimodal peak. So they got diagnosed in their between age 25 and 29, as well as that sort of same early 60s peak that the men had. And so I think this is an important distinction because women in their 20s have a menstrual cycle that will be very sensitive to this tumor. And so that is a period in life for that gender that is associated with a higher likelihood of diagnosis because of the presence of the menstrual cycle as a very sensitive metric clinically for a patient with a pituitary tumor. And then when we look at treatment, whether patients receive treatment or not, it's above the age of 70, the incidence of treatment starts to plummet, and the incidence of no treatment starts to rise. Not surprisingly, with a benign condition in older patients who might have other comorbidities, they may not always be offered surgery in that setting. So I'm at about the halfway point. I think it's a nice chance to transition from the first portion of this talk to the second. And so the second portion of this talk, we are going to focus on the natural history of observed pituitary tumors. And so to start with, we want to ask the question, what is an incidentaloma? What is, you may have heard this term before. And basically an incidentaloma is and I've put quotations around it because, but it's the word asymptomatic. And the reason I've put quotations around it is it can be tricky to know for sure whether something is symptomatic. I think as providers, we are sometimes guilty too often of dismissing potential symptoms as being unrelated, and I'll touch on that in a moment. But basically an incidentaloma, with that caveat, is an asymptomatic tumor found in an MRI or CAT scan that looks like a pituitary adenoma or pituitary neuroendocrine tumor. And why would patients undergo MRIs or CAT scans that led to this diagnosis of a pituitary tumor? Well, in the case of incidentalomas, the categories that are typically reported as being unrelated to the tumor and therefore makes the tumor an incidentaloma would be vertigo, because there isn't really a good mechanism as to why a pituitary tumor would cause vertigo. That's, anatomically a condition that's more associated with the, with the inner ear or the cerebellum. Hypertensive crisis, pituitary tumors generally don't elevate your blood pressure to that level. Head injury, obviously, if they're looking for signs of trauma, a pituitary tumor isn't going to be related to why they got the MRI. Tinnitus, just like vertigo, doesn't really localize to the pituitary. And sinus infections aren't really, related to the pituitary as well. The tricky part in terms of symptoms that many series will call unrelated, but subsequent data has shown may not be, is headache. So headache is the indication for scan or MRI or CT scan in 10% of the patients in the series in the literature that describe incidentalomas. But headache, at least in our institution, we don't typically use it as something that would be considered an incidental finding because we just don't have a good way of knowing whether or not it's related, and I'll touch on that in a moment. And incidentalomas, importantly, may cause hormonal dysfunction on laboratory evaluation and may even cause visual field deficits when the patient undergoes ophthalmologic examination. But neither can be symptomatic in order for the tumor to be considered an incidentaloma. So you can have an incidentaloma in a patient with a low testosterone, but the patient has to deny symptoms related to that, is the important distinction. So the incidentaloma literature is distinct from the sort of healthy volunteer MRI literature. The healthy volunteer literature reports about a 0.2% incidence of macroadenomas, whereas published series of asymptomatic tumors that were called a pituitary adenoma have reported a large portion, and in some cases a majority of their tumors, as macroadenomas. And the likely explanation for this disparity is that some of these incidentalomas may actually be symptomatic, as I mentioned, particularly with headache. And so I think if you subtract those out, you get a much better match in terms of how many of these tumors are macroadenomas, but it's still not as good as the match as the low level of macroadenomas you see in healthy volunteer MRIs. And so at some level, it's very hard to tease out, but people who are undergoing an MRI for some reason, whatever it is, some subset of them are symptomatic. They're just not documenting it correctly. But to me, a true incidentaloma, and the example I've shown here, Las Vegas is becoming increasingly more and more the entertainment hub of the country, if it wasn't already, with Formula One racing and all this stuff. And so you see here in the upper rows MRI on a 26-year-old male who was drunk and fell down in Las Vegas and had a Rathke's cleft cyst. So not a pituitary tumor, but still a pituitary imaging finding. But these incidentalomas can get, from time to time, can be pretty significant. This is an example of a patient with a 68-year-old male who was in a car accident with some headaches afterwards, some confusion, and had this very large tumor that was a pituitary neuroendocrine tumor for which she underwent surgery, but with no evidence to suggest it was the cause of the car accident, including documentation of good vision, etc. So the tumors that are found in normal volunteers do tend to be smaller than those in patients with headaches, which is getting at this question I mentioned earlier. So here you see an example of normal volunteer, tiny little thing over here. Patient with chronic headaches has about a 17-millimeter tumor. And it gets you thinking, is the tumor in the patient with the headache really an incidentaloma, or is it the cause of the headaches? So there's been a couple of good studies on this. We've had one at UCSF published in 2016. There's been really a number of good ones throughout the country, but I refer to this study, which is older, from 2008, because I think it was the first study that got people in the field thinking about the connection between pituitary tumors and headaches. And this is a study in which, and again, the background here is that headaches occur in less than half of the population, and occur in about half of the patients with pituitary tumors. So given that you're talking about two things that are very common, pituitary tumors, as I've been mentioning throughout, and headaches, it's very hard to convincingly establish a link between the two. But this study, which I mentioned in 2000, is now an old one, an oldie but a goodie, was published in 2008 and had 41 patients with headaches and microadenomas. Adenomas or pituitary neuroendocrine tumors smaller than 1 centimeter. And they found that when these patients underwent surgery, about 85% of them had improvement in their headaches postoperatively, and 58% had resolved headaches. This is, in their opinion, and I tend to agree, represents some level of evidence that those headaches were related to the pituitary tumor. There's been other series in the literature. We've got a group of patients who not only had resolution of a headache that we've collected nationwide group of patients, but there's a group that the tumor came back 5 years later or whatnot, and they had their headaches came back along with it. And so I think there's some convincing evidence that in a small subset of patients, not everyone by any means, headaches may be related. Unfortunately, it's very tricky to tease out whether a patient's headaches are coming from a pituitary tumor. There's no blood marker or imaging marker that will answer that question definitively. I do think, this study might be overstating the degree of improvement, but even if you bump it down to, 50%, it's, something that can be mentioned to patients. One would hope that you're operating on tumors whose size is reasonably large enough to justify the procedure in the setting of a patient with headaches. Unfortunately, the connection between tumor size and headaches is somewhat tenuous, as this original study alluded to, with such a high level of headaches in patients who had just small microadenomas. So that's all I wanted to say on headaches. The other thing we'd mention with imaging in incidentalomas is much like, cutting the slices thinner on an autopsy led to more frequent diagnosis of pituitary adenomas or pituitary neuroendocrine tumors. Getting higher resolution MRI scans with thinner slices, as we call them, also increases the prevalence of pituitary adenomas or pituitary neuroendocrine tumors. And it's really getting the slice cuts down to 3 millimeters or 1.5 millimeters that allows you to pick up more of these. It's not surprising. We're looking for microadenomas if we're talking about incidental findings. And that slice that really represents the slice at which you're going to see, a 1 millimeter or 2 millimeter adenoma. And if you're doing slices at 5 millimeters, you're likely to miss something like that. The other thing about MRIs showing pituitary tumors is, as we like to say, if you show a pituitary MRI to any radiologist and say, we think this patient has a pituitary tumor, they can find a spot for you. These MRIs can sometimes be like looking at a picture, a painting in the art museum. It's really in the eye of the beholder. And that's why it's important to, if you have an MRI in general in your practice, even if we're not talking about incidental findings, maybe a patient with Cushing's disease, but if you have an MRI that shows a tumor, getting it looked at by multiple people or getting multiple MRIs is an important way of establishing concordance. And this is a study in which having an MRI reviewed by 3 reviewers or at least 2 or more dramatically reduced the prevalence of adenomas, whereas 1 individual reviewer had a pretty high likelihood of identifying MRIs on identifying pituitary tumors on patient MRIs. So what is the natural history of incidentalomas? And this is something that, perhaps of all the things I've mentioned today might be most relevant to patients in the audience who may have had an MRI, or maybe they have a loved one who's had an MRI that shows something and the doctor says, oh, we don't need to worry about this, we can follow it. And so you may be wondering, what are the odds that my tumor may grow? And so I think I'd like to highlight a couple of studies from older to more recent, including our own data at UCSF on this topic. This is a study that I consider very intriguing, from a group in Japan, and it has stood the test of time and has matched what other centers have reported. This is 42 asymptomatic incidentalomas followed for 1 to 14 years. The initial tumor size when these patients were diagnosed was actually larger than most of the literature on observed tumors, which tended to average out to less than 10 millimeters. But in this group in Japan, they were observing a number of large tumors and with average size of 18 millimeters. In half the patients, 21 of the 42, the tumor increased by over 10% during the observation period. And the increase occurred at a wide range of intervals after the diagnosis, anywhere from 8 to 58 months. And the symptoms were noted in 10 of these 21 patients during follow-up. 4 of them had an actual emergent event of pituitary apoplexy with bleeding into the tumor. And 12 of the patients overall went to surgery. 10 of them had developed symptoms, and 2 of them had asymptomatic enlargement. Interestingly, symptoms only developed in tumors whose initial size was above 15 millimeters. And this is an important thing because right now we use 10 millimeters as this dramatic cutoff, where we even changed the name from micro to macro. But one of the things I'd like to talk about in the next few slides, including this one, is, that cutoff is somewhat arbitrary. We're really just prisoners of the metric system, where 10 is a nice round number at which millimeters become centimeter. And we say that that's, a threshold at which we call it a macroadenoma instead of a microadenoma. But does that really mean something to the patient who's undergoing observation? This study sort of implied that 15 millimeters is the cutoff at which something bad might happen. So that's one take-home message from this study. I think the other take-home message from this study is that, we try to reassure patients that if you undergo a sufficiently close observation, we're more likely to catch growth before it becomes symptomatic and recommend surgery at that time. But in this study, the majority of the patients who went on to surgery did so with symptoms that occurred during observation, which is not ideal. Symptoms are not always reversible if it's a symptom like vision loss or gland dysfunction, and those symptoms may not be reversible with surgery. So we'd rather catch growth while it's still asymptomatic. But in this study, that proved challenging. But some of it has to do with some of the protocols that were in place. They were observing some very large tumors, larger than the American series, and their frequency of MRIs didn't quite replicate what we do in the US. But with those caveats in mind, I think this is a very compelling and one of the early studies in this area of observing tumors. One group went back and pooled together. I think the thing about studies like this is the more you can pool together data, the more you learn. And they pooled together data from over 200 patients who were followed on average for 5 years. Most of these cases were microadenomas, about 2/3 of them were, in fact. And during the observation period, 10% of the microadenomas grew compared to 20% of the macroadenomas. And they didn't, this data was hard to disaggregate in a way where you could look at what happened if you use a 15 millimeter cutoff. But the authors suggest that the 10 millimeter cutoff is where they feel like, most of the changing in growth potential occurs from that 10 to 20% doubling in growth rate type jump. Interestingly, there were some patients whose tumors shrank during the observation period. There's not really a biologic explanation for this other than the possibility that some observed pituitary microadenomas or pituitary adenomas or pituitary neuroendocrine tumors might have a small asymptomatic bleeding event, so not an apoplexy, but just hemorrhage into the tumor that certainly would shrink over time. But it seems like a higher number than the number of people you would expect to have something like that happen. But for the most part, I would say the shrink or no change can be pooled together. And this sort of pooling of all the data suggests that the likelihood of your tumor growing doubles if you start out with a macroadenoma, but still that the majority of patients even with macroadenomas can be safely observed. We've looked at this recently at UCSF in 198 incidentally found tumors. Again, in this case, for some reason, we also had a more common phenomenon of observing small macroadenomas rather than microadenomas. In some cases, the observation was due to patients' comorbidities, et cetera. But what we found is if you plot the tumor size on the x-axis and the growth rate in milliliters per year, so it's volumetric growth rate per year of observation on the y-axis, 10 millimeters or 1 centimeter really is a sharp cutoff. Everything below 10 millimeters really doesn't grow meaningfully. And the majority, certainly not all of them, but the majority, more than half of them, when they're above 10 millimeters, they will grow during the observation period. And if you were to use 15 millimeters as the cutoff, as the Japanese group suggested, you're not really gaining a lot because you're missing out on these cases that grew. And, you know, there's the rate of non-growth is pretty low above 15 millimeters, but it's also pretty low between 10 and 15 millimeters. So, you know, I think this, as an isolated screenshot, would suggest that 10 millimeters is a reasonable threshold above which tumors can grow versus below which they don't. And, you know, 10 millimeters is a reasonable threshold at which one could consider offering surgery to a patient with an incidentaloma as a way of protecting against future symptoms. But I think this data, you know, got us thinking, and, you know, growth rate as a volume, you know, is a not a perfect metric, because a tumor that's 5 millimeters could grow by a millimeter, and that's not much of a growth rate in milliliters per year, but it's a high percentage of the initial tumor size. And so we sort of replotted this data showing the percentage rate in the tumor per year. So, you know, tumors can grow 20% per year is what the 20 would mean on the y-axis. And we take the same tumor size on the x-axis. Now we find that a lot of those tumors that were 5 to 10 millimeters are actually growing, you know, percentage-wise as much as the bigger tumors. There's still an upward linear trend, as you see here. So larger tumors do grow at a higher percentage rate, not just a higher, you know, linear rate or higher volumetric rate, but a higher percentage rate. But that rate of change as tumors get bigger is not quite as large as the previous slide would suggest. And, you know, this slide sort of suggests that, I mean, it's fine to use 10 millimeters as a cutoff, but, you know, the patients who have tumors less than 10 millimeters need to be observed with an actual protocol. They can't be necessarily discharged from somebody's clinical practice, because some portion of those tumors are going to grow at a pretty large percent per year. You can see example here of tumor that, you know, microadenoma, pretty small, 5 millimeters, but during the observation period, it's, you know, 80% growth, which is almost doubling. And at some point, if you've got tumors with that rate of percent change growth, they're going to eventually become macroadenomas, which is fine as long as you're observing them, but illustrates the importance of these patients not being lost to follow-up. And then how often do observed macroadenomas, again, this is the UCSF experience, end up needing surgery? And, you know, we found that about 50% of our observed macroadenomas ultimately needed surgery, compared to just 20% of our observed microadenomas. And so these are patients who are undergoing surgery generally for some type of volume growth, but in some cases it could have been the development of symptoms even in the absence of tumor growth. Incidentalomas, when analyzed across gender, turns out that while the registries show that these tumors are more common in males, incidentalomas are actually more common in females. In particular, women were more likely to have microadenomas. There's a number of reasons for this. One, and several of which I've mentioned today. One is that the menstrual cycle makes it, you know, as a clinical metric, makes it more common to diagnose these tumors in women, particularly young women. The other thing is that the microadenomas that women will be more likely to be diagnosed because they also have a higher incidence of things like headaches that lead to MRIs. And so for these reasons, it's not surprising that this gender disparity with incidentalomas being more common in women, but the registry is suggesting that they're more common in men. Are incidentalomas, you know, more quiescent or sort of slower growing than, or slower proliferating than symptomatic tumors? And this was demonstrated by a study shown here in which topoisomerase 2A, which is really just a marker of proliferating cells, the level of that marker was greater in symptomatic non-functional pituitary adenomas than it was in incidentalomas. which suggests that symptomatic tumors are actually proliferating more than incidentalomas. And another study found a slightly different result, that incidentalomas had a lower MIB1 labeling index. So same idea that that the incidentalomas are less proliferative, but in this case they're using MIB1, which is a marker for proliferating cells, but the same idea as the topoisomerase from the previous slide, which is just a different marker for proliferating cells. So I wanted to leave some time for questions, but I'm going to just sort of summarize before we get to questions to make sure we're all on the same page. And so I hope I've shown you today that cancer registries from Europe and the United States, which have been recording benign tumors since the 1950s, have shown a increasing number of newly diagnosed pituitary tumors with a plateau in around the last 5 years, and a possibly even a decrease in the incidence within the last 2 or 3 years. Autopsy series show that pituitary adenomas or pituitary neuroendocrine tumors are about 700 times more common than the clinically symptomatic tumors that are making it into cancer registries. And the autopsy series shows no increase, so that would suggest that the registry increases really just represent uncovering more cases due to MRIs. But even with these advanced imaging modalities and more common access to MRIs, less than 1% of the adenomas that exist in our population are discovered during the patient's lifetime. The disparity between the autopsy and registry data, while it could reflect underreporting, the Belgium case series still finds that the prevalence of pituitary tumors in the clinical population is nearly 180-fold less than it is in people undergoing an autopsy. And so the disparity, based on this information, the disparity between autopsies and registries most likely reflects a number of tumors that are just not diagnosed when the person is alive. And a portion of those could be hormonally active. And so that's an important take-home point. The autopsy series have shown that tumors are equally distributed among genders, but registries show them to be more common in males than females. And this is suggesting that there's more undiagnosed, unreported tumors in women compared to men. So I think moving forward, it'll be very important for us to work as a healthcare community to identify previously undiagnosed symptomatic adenomas. And I think no study can estimate what portion of the 17% incidence, that sort of 1 in 6 number I mentioned earlier, and the 1 in 1,000 estimate from Belgium are symptomatic adenomas. But the fact that 42% of the autopsy cases stain for prolactin and 1 in 600 of the autopsy cases are MAC or adenomas suggests that the number of symptomatic undiagnosed tumors is large enough to warrant a comprehensive approach at multiple levels. And so that approach, just put up here 3 ideas for how we can approach and improve the diagnosis of these tumors. The first would be, educating our primary care colleagues for the indications to screen for pituitary adenomas, so that we don't want them finding true incidentalomas. We don't, the healthcare dollars are too valuable to be sort of scanning more people with, and without symptoms. So that shouldn't be the goal of what we're doing. But we just want our medical providers to be aware of symptoms that could potentially be from an adenoma, like decreased energy, loss of libido. These are symptoms that are often attributed to age-related decline, but may not be reflective of age, could be reflective of a pituitary adenoma or pituitary neuroendocrine tumor. I think it's important to fund efforts and advocacy efforts to get insurance companies to broaden the indications for imaging, and insurance companies to report the referral of patients with asymptomatic lesions to centers of excellence. It's the asymptomatic scenario where somebody has the time and the bandwidth to identify, to meet with experts, because they're not dealing with an emergent problem. They're just trying to get better insights, and the best insights you can get are going to be from providers who've cared for so many of these patients. And lastly, I think we need more research at academic centers and centers of excellence to identify when we should be observing these tumors versus when we should be operating on these true incidentalomas. So with that, I'd like to thank you for your time today and open it up to questions.
Thank you, Dr. Augie, for another fantastic presentation. We have one question so far. Everybody, if you have any questions, please send them in now. Our first question is there a hereditary component at play, and is that something that could be screened for?
It's a great question. So there are some genetic conditions associated with these tumors. Generally, most of those conditions involve, would lead to a patient getting tumors in other parts of the body. So in general, these are so common that we don't screen for genetic condition in one patient who's an isolated, part of a family lineage or family tree. But if a patient's report who have a pituitary tumor report one primary relative with a pituitary tumor, then they may get referred for that sort of testing. My sense is that there are other genetic conditions that we haven't even found yet that could explain links between why certain families have more of these tumors than others. But for now, the number of conditions that we can test for is such that we don't really do it up front, but we instead wait till we get more of a family history.
Okay, thank you. The next question is, what amount of growth leads you to refer for surgery if HA is the only symptom?
It's a good question. And so I think it's really two variables. It's growth combined with the size that it was initially. So, obviously with a big tumor like, 20 millimeters, we might recommend having it removed even if it were asymptomatic. But if you were to observe a big tumor like that, it wouldn't take much growth for us to be expressing some concern to the patient. But a 3 to 4 millimeter tumor, you could let them grow and double and still be pretty safe. So it's a combination of the amount of growth and the initial volume or size that determines that.
Okay, thank you. And that looks like that's all of our questions today. It was a fantastic presentation. Everything was covered so well. We really appreciate you doing this tonight.
No problem. Have a good night.
You too. Thank you so much.
Bye-bye.
This will conclude today's webinar presentation. We appreciate you taking the time to join us. If you missed any part of this webinar, or if you'd like to share it with family members or friends, it will be available on our website at www.pituitary.org. There will be a brief survey after the webinar. Please fill it out to help us provide you with the information you need. Thank you for joining us, and enjoy the rest of your day.